Okay, this video is called Brain Artery with a Hand Trick. I just made a video about my credentials, but just in case no one else doesn't see that, basically I did a fellowship at Harvard in vascular interventional radiology. Well, it was interventional radiology with the emphasis on vascular disease. I did a surgical internship. I was considering becoming a neurointerventionalist, so during my neuroradiology fellowship, I initially did 2 fellowships combined. Interventional, meaning the neurointerventional procedures in the brain, as well as diagnostic neuroradiology, which is like reading the brain MRIs. And I was a previous textbook author of interventional, and I wrote it during my fellowship year. So I got a lot of experience. I did about 400 catheter cerebral arteriograms or more than that. And I don't know the exact number. I did some during residency, I did some during private practice, and I did some during one of my other jobs, and then some during I did tons of them during my fellowship in neuro. Anyways, I got a lot of background working in the blood vessels of the brain. I look at them every day. All right, so next thing here, we're going to just talk about simple rules, and I'm going to teach you what I call the hand trick. I made up this stuff. It's useful. Okay, here's the aorta. Here's the brachiocephalic artery that bifurcates into the right subclavian and the carotid, but it's the brachiocephalic right here. Brachio for arm, cephalic for head. Here's C for carotid, left common carotid artery, and here's S for subclavian. So, residents, students ask me, how do I memorize all this stuff? And I just say it's the ABCs. Aorta, brachiocephalic, carotid, common carotid, and subclavian. Easy. ABCs. Okay, now we're going to get into the hand trick. So the big thing to know about the so-called hand trick is this, and I made all this stuff up, is basically you've got the external carotid artery and you got the internal carotid artery. You can imagine the patient as if their feet were towards you. So the way you can think of these arteries is whenever you look at a CAT scan, any type of imaging study, the patient's feet are always towards you. So this is my right hand, this is my left hand. Well, and what that means is, the other thing to remember is the hand trick starts out with the hand here. You can think of the forearm as being like the common carotid artery, and then the thumb being like the internal carotid artery, the ICA, and the ECA being the fingers. And the way you remember that is the thumb goes straight up into the brain. The internal carotid artery has no branches in the neck, goes right to the brain. And the fingers are a reminder that there's a bunch of branches off the external carotid artery. It's located anteriorly, and it provides all the branches to the face. So there's a lingual, there's a whole bunch of arteries all over the face. All right, that's what you need to know. That's important, and students get that confused. That's all you got to know. ECA, external carotid, got a bunch of branches. Internal carotid has none. Okay? So that is the hand trick for common carotid artery, ICA, internal carotid artery, and ECA. That will be useful. Okay. And by the way, I'll just show you those branches again. So when I look at those branches, I circled in green, common carotid artery, blood flow going up into the internal carotid artery, all these green arrows, internal carotid artery straight up to the brain. It's called the anterior circulation of the brain. The anterior part of the brain is supplied by the carotid artery. All this stuff circled in purple. So ECA, external carotid artery in blue right here, and then these are just the branches of it all in purple. So that's how you keep track of them. Okay, then we're going to talk a little bit about the arteries that go to the brain. So the big honking carotids are up here. So here's the right internal carotid because the patient's feet are towards you, left internal carotid artery. And then the internal carotid artery bifurcates. Big branch goes out to the side. That's called the middle cerebral artery. A small branch goes anteriorly. That's the anterior cerebral artery. Usually we abbreviate the middle cerebral artery as the MCA, anterior cerebral artery as the ACA. Okay. As a matter of fact, we even have a little more precision. We'll call the first segment of the anterior cerebral the A1 anterior cerebral artery, so A1 ACA. We'll call the branch that connects the right and the left ACAs as the anterior communicating artery. We're going to come back to that branch, anterior communicating artery. It's very important. And then the A2 ACA is just a continuation of the anterior cerebral artery up over through the midline part of the brain. Okay. And for the MCA, we'll call this the M1 MCA. Then where it begins to bifurcate, it'll become the M2 MCA. The reason why we number the segments, and you don't need to know this, if you're a junior student, like if you're a college student or if you're a grad student just learning about the cerebral blood supply, you don't need to know those numbers. But the reason I mention it to them, you should be aware that they exist, is because when I talk about these vessels, I'm often talking to neurosurgeons, and I have to precisely describe where I see a finding. There's a aneurysm in the M1 or the M2 segment. There's, I have to be able to tell them exactly what I'm dealing with, so because they're going to have to operate on the patient. So that's where those numbers come into play. But for our purposes, we don't need too much. The way this is all shaped like a circle, this has actually been given a name. Willis was the name of the neuroanatomist who figured this out, so it's called the Circle of Willis. And some people have described it as looking like a little creature here. Here's the arms, here's the legs, and then these are almost like the eyeballs, and that's almost like the nose. Okay. So anyways, this is the Circle of Willis. Okay, we're going to come back to this. I'm just showing you it's on sort of like the undersurface of the brain. All right, here's another closer look at the anterior at the Circle of Willis. And again, here's the A1 ACA, anterior cerebral artery, the communicating branch of the anterior cerebral. We call it the ACOM. All right, and then here's the A2 ACA. So here'd be A1 ACA, and then the number for 2 is A2 ACA. Okay, here's the internal carotid artery coming up into the brain. Okay, then this is the big side branch here. This is the middle cerebral artery. All right, now in the posterior circulation, so the carotids are the anterior circulation supplying the anterior part of the brain. In the posterior part of the brain, what we've got is the vertebral arteries. They come up the vertebral column in the posterior aspect, and then they join together the right and the left vertebral artery to form the basilar artery. Okay, they've got 3 branches worth knowing about. The bottom branch is called the posterior inferior cerebellar artery. We just call it pica, and pica comes off the vertebral artery. So this is pica off the vert. Sometimes the vertebral artery will be small in diameter, and sometimes it'll even end in pica. But normal standard anatomy is for it to continue upwards and join with the vertebral artery from the other side to form the basilar artery. The next branch worth knowing about is the AICA, anterior inferior cerebellar artery. And then the top one of the basilar is the superior cerebellar artery. So we just make a mnemonic for these. SAP, SAP, SAP. That's what is worth knowing. Okay. Then you also, and all that stuff is below the tentorium, so that's called posterior fossa, to be below the tentorium. The tentorium is like a tent canopy on top of the posterior fossa, on top of the cerebellum. So all this stuff, SAP, is all infratentorial. Then above the tentorium is the posterior cerebral artery. This is going to go to the occipital lobe. So we will come back to that in a moment. We usually call it PCA. So all these arteries typically in conversation are abbreviated. This is PCA for posterior cerebral. Middle cerebral artery, MCA. Anterior cerebral artery is ACA. That's how we talk about them. We talk about them every day. All right. When you look at the Circle of Willis, again, the big branch here is the internal carotid artery coming up into the Circle of Willis. And this would be a complete Circle of Willis with connecting arteries all throughout. Okay, so the anterior cerebral comes up and then the ACOM connects it. The reason why the ACOM is so important, the anterior cerebral artery, is we'll often get little aneurysms on there. So that is called an ACOM aneurysm, and they look like a little berry on a tree. So we call them berry aneurysms. Okay. And the ACOM is the most common spot. That and the PCOM. So ACOM and PCOM. So right here at the origin of the posterior communicating artery, this is the posterior communicating artery. We usually call it the PCOM. You'll sometimes get aneurysms there. Most patients don't have them. I can tell you 99%, it's even more than 99%. In my experience, it's probably about 99. And I know my numbers are not going to match the books, but I'm just telling you, personal experience, 99.9% of the time, we never see an aneurysm in these arteries. But when we do see one, it'll most commonly be in the ACOM or the PCOM location, or it'll be an M1 M2 bifurcation aneurysm. Those are the most common ones. Yes, I've seen them in the top of the basilar, I've seen them in the pica, but those are super, 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 super rare. Okay, so we often see normal variants where you get a little dilation at the origin of the PCOM called an infundibulum, or an actual aneurysm is actually relatively rare. More common in women than in men, more common in smokers and hypertensives. And there's a few anatomical variations that increase the risk, but they're still pretty rare. So don't worry about it. The likelihood of you dying of an aneurysm is less than, being bitten by it's something like about as likely as being bitten by a shark. Okay, so it's a rare thing, but one still, in my business, you got to know about it. All right, so here's an MRA, combined view, kind of a fancy word. Well, you just need to know this is sort of looking up at the arteries, and they're all superimposed on top of each other. So again, this would be the internal carotid artery, comes up, and then it splits right here. It splits into the middle cerebral artery, MCA, and the anterior cerebral artery, ACA. So you can see an intact A1 ACA. Here it's labeled A1 ACA on both sides. Okay. And now the reason I'm showing you this, and there's something useful on this film here, is that you've got a large posterior PCOM artery here. PCOM, posterior communicating artery. It's very robust on the left side. On the right side, it's hypoplastic atretic, very small. Okay, that'll end up sometimes being relevant. If you got a big PCOM, we call it a fetal type, embryology, fetal development, a real robust bilateral PCOM, then the basilar artery and the associated vertebral arteries will be small, hypoplastic. I'll talk about that normal variant in just a moment because it is relevant. Okay, now I'm going to show you how do you memorize what's happening with the middle cerebral artery. So the middle cerebral artery, so the anterior cerebral artery comes up in the brain like the thumb trick. And by the way, here's how you make sense of a brain. The thumb is the temporal lobe. The front of the knuckles here is the frontal lobe. The vertical crease here is the central sulcus of Rolando. So in front of it is frontal lobe. There's a pre-central gyrus, the primary motor, post-central gyrus, primary sensory for touch, vibration sense, position sense. And then after that, you'll be in the parietal lobe here. Back here is occipital lobe, almost purely sensory for vision. Okay, so the MCA, like I said here, the internal carotid artery comes straight up into the brain, like this, and then it bifurcates, and the MCA goes out around the side. All right, so the way you can remember the arteries, and the MCA goes right down the middle. You can remember them as the middle anterior cerebral artery is like a mohawk haircut, like this guy, a mohawk haircut. Whoop, and it's good to do it to yourself. That physical motion, just do that yourself, making a mohawk sign with your hand. You will remember it. Okay, now here is like Bozo the Clown used to be a famous TV show when I was a kid growing up. And so you see how he's only got hair on the sides. And as a matter of fact, just male pattern baldness, like what I got, where my black hair is, that's where the middle cerebral artery supplies that part of the brain. So where my bald head is, the mohawk area, that's the anterior cerebral artery, right down the middle. And then the MCA is to the side, and that supplies like a bozo haircut or just like male pattern baldness where my black hair is. Okay, and then what's the point of the last one? The last one is, imagine you took your eyeglasses and you put them on backwards. I think I got eyeglasses around here. So here's my eyeglasses, all right? And I take them and I put them on backwards on my head like this. Okay, that tells you where the posterior cerebral artery goes. And it's a good reminder too, because you're wearing eyeglasses, and that's where you've got vision in the occipital lobe in the back there of your brain. So that's an easy way to remember these vessels. ACA is a mohawk, MCA is bozo hair or male pattern baldness, PCA is glasses on backwards, like for the occipital lobe. Now I'm just going to show you an example of where this anatomy starts becoming relevant. So let's say you got a patient here with atrial fibrillation. Atrial fibrillation patients sometimes form a blood clot in the left atrial appendage. There's a little pocket of tissue where you can sometimes form blood clots, especially in AFib. All right, that clot can then be tossed up to the brain, and it'll go up the internal carotid artery, and it'll most commonly, because it's the biggest vessel, go out the middle cerebral artery, and then it'll lodge in the smaller branches as they extend up over the cerebral convexities. Okay, so that would be your sort of typical MCA, big MCA stroke. Okay, and another reason why I recommend all these low-fat diets is you help keep these arteries open, and you're less likely to ever develop atrial fibrillation in the first place. Low-fat, low-sodium diet. Okay, so anyways, so here is a CT arteriogram, CAT scan arteriogram, and you can see a normal MCA extending out here. You can see the ACA right there, and here's the MCA, and it goes out over the cerebral convexity, meaning the side of the brain. On this side, though, there's an abrupt cutoff where you don't see any vessel, and that's because this thrombus from the heart was tossed up to the brain, and it's blocking this artery right here, and this patient had a stroke. So they'll have sudden weakness on the other side of the body, sudden weakness of the left side of the body, left arm, left leg. So unilateral, abrupt onset unilateral hemiplegia would be the history. Rule out stroke, and this would come in as a CT arteriogram. This is the kind of thing I read all the time. Okay, I used to do the catheter arteriograms and do these procedures, but it's a long story where I ended up deciding not to do a neurointerventional, continue with that, but I had a lot of training in it. Okay, so now here is the catheter arteriogram of this patient. You can see the middle cerebral artery is occluded. The M1 MCA, distal M1 MCA is occluded with abrupt cutoff consistent with an acute thrombus due to an acute embolus. Embolus is a clot that moved from one location to another. So in our patient here, from the left atrial appendage up into the right M1 MCA. Now, the neurointerventional radiologist, endovascular surgeon, has placed a guide wire past the clot, and now he's got his catheter past the clot, and it's a special type of catheter wire that has a basket device on it to pull the clot out. So this has been advanced distal to the clot, and then it's retracted posteriorly, and the basket catches the clot and has pulled the clot out of the artery. So they were able to save this artery. So now you've got a nice open artery, and hopefully you will not have had enough brain damage that's irreversible, because brain cells can be irreversibly destroyed in 4 minutes of hypoxia, lack of oxygen. Okay, so that's how it's done. So this is a transcatheter thrombectomy of the right MCA, for right MCA embolus. Okay. So again, if you're looking at it, this is the carotid artery coming up, bifurcating into the anterior cerebral artery, and then it goes up through the middle of the brain, in between the two right and left sides of the brain, cerebral hemispheres. And here's the middle cerebral artery here, and then here's the convexity branches. And this is where the clot was initially. And here it is, the post-clot removal, post-thrombectomy catheter arteriogram. And it looks really nice. The artery is wide open. It's beautiful. Okay. There's a tiny bit of spasm right here in the cervical carotid at the skull base. Whoop-de-doo. That doesn't matter. Okay? This is a magnificent result. All right, so getting back to this, I wanted to remind you again, here's the carotid artery coming up, goes into the anterior cerebral artery here and the middle cerebral artery, but here's this posterior communicating artery. Here it's written, posterior communicating artery, posterior communicating artery. Okay, and that communicates with the basilar, so that's sort of the circle of Willis, meaning that the anterior circulation of the carotids is connected to the posterior circulation of the basilar. We talked about the aneurysms, but what I'm going to emphasize at this point is take a close look at this PCOM, posterior communicating artery, which can be a good anastomosis to supply blood from the front to the back, etc. All right. Now I'm going to show you some of the other things relevant to this. Okay, here is what the posterior communicating artery looks like from a side view. It connects the anterior circulation is the carotid coming up into the anterior part of the brain. The vertebral arteries travel within the foramen transversarium of the vertebra, and that's the posterior circulation of the brain. There's only one artery on each side in the front and the back. So the single artery in the front is the internal carotid artery going to the brain. The single artery in the back is the vertebral artery. And then as they come up, it forms a basilar, and then the basilar can be joined to the carotid here through the PCOM, posterior communicating artery. Okay, that's going to be real relevant in just a moment. So here is a hypoplastic or atretic or very small PCOM on this side, diminutive, where then you got a big honking robust PCA on this other side. So you can imagine if you had an artery block somewhere, it'd be nice to have an intact circle of Willis to provide collateral circulation, good detours to bypass the blockage if it were to occur. Okay. Now I'm just going to show you a normal variant here real quick. So here's standard conventional anatomy with an intact circle of Willis. Here's the carotid arteries, ICA, internal carotid artery coming up to the brain, middle cerebral artery over here, anterior cerebral artery over here, ACOM between the anterior cerebral arteries. Good, moderately developed PCOM, and that's what it typically looks like. And here's the basilar artery, P1 PCA, P2 PCA, posterior cerebral artery. That's your standard conventional anatomy. Okay, now here's something though that I do often see. This is called bilateral persistent fetal type PCOMs, meaning during embryological development, the fetus will have very big relative to the other arteries, PCOMs, posterior communicating arteries. Sometimes they stay big. And if you have bilateral fetal PCOMs on both sides, you're getting a lot of blood supply going retrograde into the basilar and feeding both PCAs, posterior cerebral arteries. So what this means is the basilar artery never has much reason to develop because the big persistent fetal PCOMs coming off the anterior circulation carotids are supplying the occipital lobe. So you don't need much of a basilar. And you don't need much vert flow because it doesn't take a lot of blood to supply to cerebellum and the brainstem. So in this types of patients, they'll have tiny little basilar arteries, tiny little verts and basilars. So this is called bilateral persistent fetal PCOMs with associated vertebrobasilar hypoplasia. And I do see this often. I see this about once a week. Okay. All right, so what's the consequence of that? Well, what this means is when you have a small diameter vessel, you got to remember there's a lot of small penetrating arteries that go into the brainstem here, into the pons, for example. Plus, we had talked earlier about the AICA, anterior inferior cerebellar artery, going back to the cerebellum and the superior cerebellar artery. Well, what this means is if you get atherosclerotic plaque, like the typical cheeseburger-eating American who eats meat and dairy and processed foods, they can plug up the posterior wall of this basilar artery and it's so small that it can plug up the arteries coming off it, the penetrating arteries into the brainstem, and the ICAs and the SAPs going back, the SCA is going back into the cerebellum. Okay, so what's the point? These patients are at increased risk for stroke. Okay, here's an article to that effect. Bilateral vertebral artery hypoplasia and fetal type variants of the posterior cerebral artery in acute ischemic stroke. The patients who have this have an increased risk of stroke. So they should be extra careful of the risk factors. But the truth is nobody knows until they've had a stroke, because you never check this anatomy unless you're working up a stroke. So here's a persistent, bilateral persistent PCOM. See how you got big honking PCOMs on both sides and you can barely even see the basilar? It's diminutive. Same thing over here. Big honking PCOMs, no basilar. So these poor patients had a bunch of strokes. Pop. These little bright spots are strokes. This is a diffusion weighted image where the strokes are the white spots. So pop, 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 pop. There's a whole bunch of little strokes. Pop, 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 pop. Okay, so that's why nobody knows whether or not you got bilateral persistent fetal PCOMs. You don't know. You very well could. And so what that means is these people are at increased risk for stroke. So the smart move is just assume you got it and optimize your health so you never develop a stroke. If you optimize your health, your odds are like close to zero of ever having a stroke in your life. So that's the smart thing to do. That's what I do. All right, so anyways, that's basically it for the artery of the brain. So the hand trick was simply knowing the lobes of the brain. We talked about this: temporal lobe, occipital lobe, frontal lobe, posterior, the parietal lobe, and then we talked about the hand trick showing you the thumb goes up into the brain as anterior circulation as a carotid, and then these guys are the external carotid. This is the common carotid in the neck, and basically, and then I showed you, remember, we did the MCAs, male pattern baldness, MCA to the side, ACA is a mohawk, okay, and then put your glasses on backwards, that's a PCA. That's all the arterial anatomy you could ever expect a medical student to know. And with these tricks, I think it's pretty easy to remember. Hope that's helpful.